You're listening to the second season of Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to the second season of Medscape's In Discussion series on type 2 diabetes. Today we'll be talking about the use of technology, specifically CGM, in type 2 diabetes. First, let me introduce my friend and guest, Davida Kruger. Davida has been a certified nurse practitioner in diabetes for more than 40 years at Henry Ford Health System in Detroit, Michigan. She is past chair of the American Diabetes Association's Research Foundation and past president of healthcare and education of the American Diabetes Association. Welcome, Davida.
Oh, it's exciting to be here today. Thank you, Carol, for having me.
It is my honor to have you here today. I always like to ask each of my guests a question that helps the audience know a little bit more about them. And I think it'd be very interesting for the amount of time that you have been practicing in diabetes. Tell me a little bit of what has changed over the last 40 years.
Well, Carol, I'd have to say everything. You know, back in 1982, when I first started, we didn't even have blood glucose monitoring. It came in shortly after, and then we had to remind patients not to pee on the blood glucose strip because that's all they knew. And, you know, it needed a lot of blood, and they were very costly, and we did not have very many therapies. Insulin pumps were huge. We had to plug patients in at night to charge them. They had metal needles. We had to dilute out the insulin. I mean, everything is changed. And, you know, what I like to think, or I like to say, is that it's never a good time to have diabetes, but it's about the best time given the therapies and the technologies we have today.
Well, that leads into my first question. So of all the more recent changes, and there have been many, in management of patients with diabetes, what are you most excited about?
There is so much to pick from. It gets very exciting. On the medication side, it's SGLT2 inhibitors and GLP-1, GIP. On the technology side, I think absolutely continuous glucose monitoring and the changes in insulin pumps and how we are now moving that not only for type 1, but also for individuals with type 2 diabetes.
Well, you're very well known in a lot of aspects of diabetes management, definitely a leader in this field, but you're very well known about your role in promoting and educating on diabetes technology. Can you tell me more about how you use diabetes technology, specifically CGM, in patients with type 2 diabetes?
Well, you know, sometimes I get my hand slapped for this, but I think CGM is a right, not a privilege. And I really think that the insurance companies are starting to agree with that, and they are allowing it for more people with type 2 diabetes. So not just 4 injections or 3 injections a day, but we will see probably in the next year or two where it will be available for people just on 1 injection. And we're hoping for maybe people on just other therapies, because as the therapies change, we're using insulin later and later, but we don't want people with type 2 diabetes not to have CGM. So we're trying to offer CGM to almost every person who has diabetes. Why? It's not only to prevent hypoglycemia and to correct hyperglycemia, it's to make lifestyle changes and to support that patient in understanding where they've been, where we want them to go, and how to get there. So we use CGM for so many people. If we can get it from insurance, we get it, but also we see a lot of patients don't want to be without it, and they do purchase it. And then, of course, we have professional CGM as well.
So I think the feedback that patients get from wearing a CGM and making associations between what happens with their blood sugars and what they're doing with their diet and activity is so crucial. Thank you for that. So in my experience, CGM is not being widely used in primary care. Why do you think that is?
You know, We have a huge system, and we have 48 outpatient centers, all of which have primary care providers. I don't think they're as comfortable with CGM as we are in endocrinology. You know, I think of you and I as technology geeks. We live for it. We know what to do with it. We want it because it helps us with our practice and how to help the patient. But I think the primary care providers are so busy with everything else that we have to make this easier for them, because you and I are seeing more complicated patients, and that's what we should be doing. But if we're going to roll this out to less complicated patients so that they don't get complicated, we need to put it in the hands of the primary care provider. So we need to have the prescribing ability easier, we have to have coverage easier, and we have to have it easier for the primary care provider to understand the data they're looking at. All of those things have to happen.
You know, one of the things that occurs to me is that we need to make the whole workflow easier for use of CGM. I know that we've gone through the different steps of how to work it into our system, but one of the things that's been really helpful is being the integration with this, with the smartphones, and being able for the patients to have continual uploads and for us then to have immediate access for when they come in. And I think that's something that needs to really be emphasized, is that it doesn't have to make it harder in the office to use it, but it is.
Well, and one of the things I saw this past weekend on one of the newer models is I always think, oh, you have to upload it, you have to look at all this data, you have to do, well, that's me, that's you, that's endocrinology. But on the phone and on the reader, there's just one button you push and it brings the data up that you and I are used to looking at and having to go to another app and to a web. And I think that's going to be huge in the primary care world. And they don't need to look at 14 pages. They can look at just AGP for a summary. And I think those are the things that are going to make life better in the primary care world.
That's a really good point. You earlier had mentioned professional CGM versus what the patients are using at home, which we call personal CGM. Can you talk a little bit more about the differences of those?
Absolutely. So personal CGM, you own it, it's yours, the sensors get sent to you. But in situations where the patient's not yet ready, they don't have coverage, they can't afford it, we want to see what's going on in their lives, we've just met them, we put what's called professional CGM on it. We purchase the sensor, we place the sensor, and the amount of days when the sensor expires, we have it returned to us, or we go to a website and we look at it, and we can analyze the data. And most insurance companies, in fact, I haven't found an insurance company, whether it be commercial or Medicare or Medicaid, that won't pay for it 2 to 4 times a year. I can see what's going on with that patient. And so, maybe in a primary care practice, that's what they need. Before the patient's coming in, they place that sensor. The patient shows up, they have the data. So it's a really nice look-see for the data. I mean, if a patient hands me 2 or 3 blood sugars and it's 2 here, 1 there, 3, my brain still does it. It's too late. My brain doesn't know what to do with that. And if the patient doesn't have any data, I don't know what to do. And if they just have an A1C and it's too high, I don't know what to do. And if it's at goal, I worry about low blood sugar. So if I can't get personal CGM for the patient, I use professional, and so can the primary care world.
I think that's really important. So one of the things that I think the audience should understand is that professional CGM reimburses quite well. Your medical assistant can place the sensor, can activate it, can start it, and then when the data, your patient brings it back, they download it, and they give you the report, which then you can interpret and put in a separate bill for. And I think in our area, the entire bill is billed out at about $390 between the 2 different parts. And although I'm not saying this to try to help people pad their pockets, I've been saying it because I think it's important for people to realize that it's worth the time and effort for them to do, and the information is invaluable.
Yep, I agree with you 100%. And we do that. We try to make sure that we bill for the time we provide the health care. And if you're going to do it, you should get reimbursed.
Yeah. I think the other aspect that might be helpful is perhaps just a little bit of a distillation on in whom the primary care provider should be focusing in terms of their use of CGM in their patients with type 2 diabetes. How would you name, 4 or 5 scenarios where you think it would be particularly helpful?
So I would think the patient that's brand new to you and you're not sure that the therapy is working for them or what direction you want to take them. The patient who you're trying to convince to move from one therapy to the next therapy. So let's say they're on 2 orals and a GLP-1 and you're thinking you need a basal insulin. You need to convince that patient. A patient who's at treatment goal, I worry so that they don't know they're having low blood sugar. I had one person today who had 16% low blood sugar, and he contacted me because he was seeing the post highs from treatment of lows. And those are just 3 scenarios. The patient is not sure what's happening after a meal, and you can't get those finger sticks or during the night. It's really hard to get that data, and we worry about our patients having low blood sugars during the night. If I put a professional CGM on them, I can get the postprandial, I can get the overnight. And I just think a comfort level that you chose the right therapy and the patient's doing well. So those are just a few of the scenarios, and I probably could come up with 10 more. But I think as a healthcare provider, to make sure everything is safe and you're doing everything you can, and to help the patient feel comfortable with what's going on in their care.
Probably the biggest place that I use it is in a patient who has either had a sudden change in their A1C, and I'm trying to understand what's going on, or they're fasting glucoses, and, a lot of my patients who are doing finger sticks still just do them first thing in the morning, no matter how often I try to convince them elsewise. And they come in and their fastings are at goal. They're, 110s, 120, and their A1C is still 8 something. That's a patient most likely has a postprandial problem, but they might just have iron deficiency or another reason for inaccurate A1C. And so I will not start insulin until I see a CGM, because I don't like to drive with my eyes closed, and insulin has its risks, and I want to make sure I'm not over-treating my patients.
Absolutely. And I think the other thing we have to remember is that, finger sticks have been around for a while, but they can be 20, 30 or more % off of the actual lab, because there's so many mistakes that can be made by the patient, including having something on their fingertips when they're testing and they're going by that data. Or if they have CKD, it's not going to be accurate. Or if they have anemia, it's not going to be accurate. And those things also affect, of course, the A1C. So moving to CGM is just game changer in what we can offer in quality of care.
So I'm not sure you're going to have an answer for this question, but if I were a primary care provider listening to this and wanting to explore where to go next to get this into my office setting, what would be your best advice for them?
Well, I think I do have an answer for that, Carol, because I think there's a couple of avenues. So in a big center like ours, we actually have educators in each of the centers, which I think is huge. Those individuals can help our primary care providers set up their practice. They certainly can call on us. But I think that if you're in a private practice, don't shy away from the industry. So the companies that make CGM will come in and help you connect to the cloud, get samples, get product for professional CGM. And we use all comers in terms of we like to have a variety of choices. But as a provider in a small practice, you may choose one. So don't shy away from asking them to come in and help you set up from whichever company you so desire, or use community educators to come in and help you set up. There's plenty of help for you out there.
Davida, thank you for that. That's really good advice for the primary care providers. I can't tell you how important it is to just have those first steps and get over that first 1 or 2 patients in terms of the process. We have a little bit more time, and I know that you've been instrumental in some of the research that has been done on some of the insulin delivery systems that are now made available for patients with both type 1 and type 2 diabetes. Could you give us your impression about those, and how a primary care provider might learn more about those type of systems?
So first of all, I would say that insulin pumps can be very tricky. Even the easier ones can be very tricky. And I really encourage people, if they're not diabetologists in primary care, to work with your endo or educators to make sure you're comfortable, patient's comfortable, and everything goes right. But the newer pumps, the newer delivery systems are integrated with continuous glucose monitors. So what happens is if your blood sugar goes high, it gives you more insulin. If the blood sugars go low, it turns it off or lowers the insulin. And so that's the beauty of the newer devices. And then in the next couple of months, there will be a new device that comes to market that the patient does nothing. I do nothing. The patient puts it on, wakes up, tells the pump what they weigh, and it is not a time to lie. And then for each meal, all they have to do is say, this is my normal breakfast, my normal lunch, or bigger than normal. And the pump knows them well enough to give the insulin, and they don't have to do carbohydrate counting. So I'm blown away by the changes in the ease of use. And I think because of the two to come out this year, or one last year and this year, and the ease of use, that we'll see more and more of the primary care providers being able to participate in the management of our patients with diabetes, both type 1 and type 2. And there's no reason why a patient who has type 2 diabetes cannot benefit from an insulin pump.
Couple points on that. Number one, primary care providers will have to have a good relationship with a diabetes educator, because the patient education on pumps is so very important, and we don't do a very good job at that. But the second issue is that let's remember that patients with type 2 diabetes, not all of them have a lot of insulin. Some of them become very insulin deficient for various sundry reasons, and that those patients need to be treated like type 1 diabetics. So, you see a patient with wildly fluctuating blood sugars and a type 2, I usually think about the possibility that they become very insulin deficient. So not all type 2 is the same. Remember that as well. What about things like the N-pen or patch pumps? I know that you use those in your practice as well. You want to spend a minute or two talking about those?
Absolutely. So there's a couple of patch pumps on the market now. Some are for basal and bolus insulin. You just fill them, put them on, change them every day. Or there's others that are just for mealtime insulin. You fill them, wear them for 3 days, click them to get just mealtime insulin, and then take a basal injection. Those make everybody's life easier because wearable devices go with you. You don't have to find your pen. You don't have to find your syringe, whatever it is, or your insulin. It's on you. And then when we talk about something like an InPen, that's a pen that hooks up to continuous glucose monitoring. So we can see when you take your insulin, your carbohydrates, and we get your CGM data, which again, by pen, it helps us adjust the insulin you're taking. All of these devices make life so much easier for the person with diabetes. And, half the battle with diabetes is getting the insulin under the skin, literally, and making sure it's all taken. So if I can give a patient a device that makes their life easier to take that insulin, I'm all over that. And if I can get CGM data back, that's the bonus, so that I can help those patients. So absolutely, all of those are great insulin devices.
Yeah, and that particular pen we're talking about is just one of many smart pens that are coming out. And one of the advantages, again, is you as a provider can see, how the relationship of the blood sugars go to the insulin dosing and the time and the amount. And it makes it easier to help counsel the patient on where they may be having issues with, adherence or late injections, et cetera. So it is really helpful. And with the specific product that we have on the market, the InPen, they can fax from their app their data right to your fax number. And so you don't even have to do anything other than, make sure that they know to do that before the visit. So it's really, as you know, very helpful. Well, good. Any other comments that you want to make by the end of this session here?
Yeah, I just think that these devices are not only good for our patients, but I think as providers become more comfortable with them, they will realize how much it empowers them as a healthcare provider. And I really do encourage all healthcare providers, whether it be primary care or some of our endo friends, get much more comfortable with the utilization of all of these devices, and everybody's life will be better.
Thank you so much for that. That was absolutely excellent, Davida. So today we've talked about the use of continuous glucose monitoring and technology in patients with type 2 diabetes. We've talked about how important it is at every stage of the, I call diabetes journey, for us to be considering how CGM might be helpful. I want to thank the audience for joining us today. Thank Davida for her very excellent discussion. And this is Dr. Carol Wysham for In Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.